This is Jerry Hesch, and this is our case titled Sacroiliac Joint, Novel Hesch Pattern. I took the liberty of naming it using my last name. This is a pattern I've discovered several years back. It's not described in the literature. It's named Posterior Sacrum or Posterior Glide Fixation of the Sacrum. And this particular case is also titled Advanced Concepts, Unusual Distal Comepnsation. We spoke about that in part 1, and this is part 2 of that case. And this is presented to you by the Hesch Institute, which is a clinic and educational organization in Henderson, Nevada, very close to Las Vegas. Our website is heschinstitute.com, where we do consultation and treatment, and we also do distance education for hands-on clinicians. So this is perhaps 30 minutes after the part 1 was filmed, and we treated the client. We talked about the pattern of restricted internal rotation on the left. I did not demonstrate it, but spoke about it, and we changed it only slightly. So I know that that is a movement pattern in her body that I'm probably not going to change. She was struck on the left side of the pelvis against the door in the first motor vehicle accident, which was when?
Approximately 32 years ago.
Yeah, and that's the one where you hit the door, right?
Correct.
So I think that that restriction of internal rotation on the left is by design at this stage, and that we're not going to change it, but we will go ahead and have you self-treat it to maintain as much strength, and the little bit of range that we did gain, we want you to keep that. We did treat the right hip, which lacked extension, and we were able to restore 20 degrees of free and easy extension on that hip, which we'll demonstrate. We were able to reduce the pattern that we call posterior glide sacral fixation. And I do want to point out that that pattern it's a complex pattern which probably involves multiple structures. It may have much to do with fluid exchange. If you can think about the muscles that are segmented, they're like envelopes or they're like water balloons. And you had so much tightness in that area that I think this pattern is not just a joint pattern. We describe it in terms of a loss of movement. But when you look at the CAT scan, you look at the MRI and the X-rays, it did look like the sacrum was a little bit posterior. I talked about the excessive lumbosacral angle, but that was very subtle. When I see when you lie on your stomach and I see how significant the difference is, it's much greater. So I think that what we see as clinicians is a much greater amount than actually is happening in the joint. And I think that a lot of tightness in the soft tissues may explain that. But anyway, I'm going to demonstrate mobility through the pelvis now that we've treated it. I can take up your slack. It takes up fairly quickly, but I can still add additional force, and that movement, that moves through your body. And on the other side, I can take up the slack. I can spring, and you can see some recoil there, and when I let go, there's a little bit more recoil. In terms of side-to-side mobility, this is greater. Are you able to feel the difference?
I don't feel like I'm laying on my sacrum right now.
Good. So you no longer feel like you're laying on the sacrum.
I do not feel my sacrum right now.
That's really that's very interesting. So here is inferior mobility, and I can see the movement goes through the pelvis into the lower extremity. And the same thing on this side. Good. Can you lie on your stomach? So I will demonstrate that we gained hip extension on the right. Very easy. And I'm going to show a superior glide force. And I can see your head bob up and down. When I let go, there's a final recoil. A while ago, I tested springing on the sacrum, and I was really pleased to see that if I step out of the way, out of the camera view, I can see her heels roll. So the force is translating through the body, whereas before it was very, very rigid. Now here's an inferior glide. And can you capture the feet, please?
I did.
Okay, good. So you could see how that force translates all the way through. And inferior glide of the sacrum, I can load the sacrum inferiorly, and then I can spring it. So there is considerable softening throughout these soft tissues. And you recall that the sacrotuberous ligament was very taut. And now this feels to me like a normative ligament. I should be able to take up the slack in that structure. And then when I spring it, it should be very tight but yielding. Much like, say, a half-inch nylon rope that's being pulled. Okay, and that sacrospinous ligament, that also moves. So we have improved the mobility in her pelvis. And here's a forward rotational spring test. The movement, I would not describe this movement as normative yet. I would say it's still somewhat stiff. So I'm curious to see how you present when you come back tomorrow. And it might be that right now your nervous system has so much stimulation that maybe it's occulting the rest of the pattern. I do note that sometimes when people come back on the second day, they've had 24 hours of moving around, walking a little bit, sitting, getting up and down, etc. And the true story tends to emerge. It might be the case that you have another pattern, and a predictable one would be what's called the second most common pattern of faulty lumbopelvic hip motion coupling. But we'll ignore that for now. I just want to move up to the upper body. So now we'll film her right below the neck. I did mobilize rib number 5 on the left, which was painful with gentle springing on the front of the body. So we did treat that. You'll recall that she was tight with spring testing at about T6 and T5, and you can see that I can spring all the way up. So there's improved mobility here, and I'm going to have you now roll and lie on your back, please. And I'm going to stick this under there. Alrighty. I also mobilized the first rib, which was elevated. Now you'll recall that previously I spoke of the upper body of the sternum being the typical location of restriction with the pattern, but that you were more restricted in the mid and lower body. So you just want to identify xiphoid process. You never want to spring that little critter. That could be dangerous. So you want to come above that. So here is some anterior spring, working our way up. I cannot find a restriction. Okay? I'm going to spring the ribs on the left, so I'm up high here on number 3, number 4, 5, 6. All of those have mobility. Did you make a comment to me about the rib? I'm trying to recall. What you said. Oh, I know what you said. I know. It was regarding your upper cervical. When I started to, you can turn the camera up here, please. After treating everything below, I came back and I retested before I treated anything else. I came and I retested the upper cervical spine, and she still had mobility in flexion and still lacked mobility in extension. So I performed a very gentle traction to the OA joint. And then I imparted a mobilization through the occiput in an oblique direction. And you made a comment when I was doing that. And what did you say?
Oh my gosh. I forget. I'm sorry.
You said something like, that feels good.
Oh yeah. Yes, it did. It did feel good.
Yeah, so you affirmed to me what I perceived with my eyes and hands. And had you said that hurts, that would have been, disconcerting to me. But it affirmed that I was on the right track. So right now I'm going to demonstrate to you that now when I traction her, there is greater mobility, and I can see the movement occur all the way down. And when I lift up the occiput, there's easy movement into extension. If I clasp it a different way, and now I'm tractioning it essentially towards my nose, yes, there's mobility in that direction. If I come just below the occiput onto C1, there's there's anterior glide mobility there too. I did a little bit of work on suboccipital muscles also after we restored those motions. But it feels to me like you and I are on the same page.
Yes, it does.
It feels like we're in agreement with what we're finding. We then had you walk around a little bit, and your thoughts, your comments?
Everything felt like it was trying to readjust and smooth out, and I felt things unwinding in my pelvis area.
And did you feel that process stop, or did it just keep on going?
It kind of kept on going. It slowed down a little bit, but it did kind of keep on going.
Can we move the camera so she can get up and walk and just see how she feels? So we could just turn it or pause it or... Okay, come on